Professor Anne Alexandrov from the University of Tennessee Health Science Center in Memphis, Tennessee. And the name of the study is ZODIAC. We know that patients that are suffering a large vessel occlusion stroke have what's called vasomotor exhaustion in the arterial territory that is occluded. And because of that, blood flow into that region is quite passive. And so this caused us to start wondering, well, if you put the head of the bed down, would patients therefore have more flow into that passive arterial territory than they would if their head of the bed was up? We first debunked a old myth that all patients immediately have increased intracranial pressure with a stroke. That's not true in an acute ischemic stroke until the tissue in that area begins to die, and if there's limited compartment space in the skull. And after doing that, we then began pilot work exploring whether this was the case. So what we were able to identify was, first of all, that even though there's an occlusion, in about 80 to 85% of patients, there's actually blood flow that's going through that occlusion. It's just suboptimal flow that results in the stroke symptoms. And we did see, using transcranial Doppler, looking at real-time blood flow in that region, that you can actually augment the amount of blood flow by placing the patient's head down from 30 degrees by about 20%. So that caused us to look further at things like clinical change, which we saw in a small sample of patients in our early work, and then began to explore further. So the study that we did, ZODIAC, was a probe design, so a prospective randomized outcome blinded evaluation. Obviously, you can't do a double-blind protocol for this type of procedure because patients know whether their head is up or down, and also the team around them knows this as well. So instead, what we did was not tell anyone in the cath lab, not the interventionalists, not anyone working during the procedure in the cath lab, none of the physicians in training knew. The only people that knew were the study team. And we then randomized patients to either head up at 30 degrees or head down at 0 degrees, and did consecutive assessments every 10 minutes using the National Institutes of Health Stroke Scale score to look at changes in disability. All patients started with their head of the bed at 0 degrees immediately after the CT and the CT angiogram had been completed. So patients each had that as their time 0 assessment, and then the every 10-minute assessments after that looked for different changes, improvement, stability, or worsening on the NIH stroke scale. And the final assessment then was done by somebody in the cath lab. And it's quite interesting to note that our own site, our lead interventionalist, had no idea that we had been doing this study for about 6 years because we did such a good job of really masking what we were doing and just making it quite matter of fact when we dropped off the patient in the cath lab and had them do the final score for us. And we found that this was true at the other sites as well. So it came to quite a surprise to them when we announced that we would be presenting the study at the International Stroke Conference, because they didn't realize that we were even doing a study. So that tells me that the probe design was done very well, with them not even knowing that they were doing an outcome blinded assessment at the time the patient reached the cath lab. So the primary endpoint is that blinded assessment. And that's pretty much the study design. Fairly simple, fairly pragmatic. We did not interfere with the time that the cath lab procedure was about to start. We also did not interfere with patients getting TPA if there were TPA candidates. We just fit these processes into how a regular acute stroke patient that has a large vessel occlusion would be managed. So the primary endpoint, again, was the finding on the outcome blinded assessment. And what we found was that 0-degree head of the bed positioning in a large vessel occlusion patient that is a mechanical thrombectomy candidate, so viable brain, still within that arterial territory, those patients were much more stable if they were at 0 degrees and even improved in many cases if they were at 0 degrees compared to those patients in the 30-degree head of bed group. In fact, the number needed to harm to worsen 2 or more points on the NIH stroke scale was 1.88, and the number needed to harm to worsen 4 or more points was 2.48. So just about every other patient then is going to deteriorate if you put the head of the bed up. And these findings actually were not too much of a surprise because of a lot of the pilot work that we had done in advance of the study. But we really needed to show in a larger sample that this was indeed something, that could be harmful. We did not have problems with things like aspiration or hospital-acquired pneumonia, and that's because these patients come in so disabled with large vessel occlusions that, of course, we're not giving them anything by mouth right up front, and they're going off to the cath lab. So again, they're nil per os, not receiving anything by mouth during that time period. And we also had someone there every 10 minutes watching them and, making sure that their airway and breathing was fine. We followed their pulse oximetry readings very closely along with their vital signs. And so the procedure was ultimately safe as well. So it's safe, doesn't cost you anything to do it, and patients seem to benefit from it. We did also have some exploratory findings, and of course, these are more hypothesis generating. We were not powered for these exploratory findings. They were simply our curiosity that were pre-specified in our work. And we did find that at 24 hours, and again at 7 days or discharge, whichever came first, that patients in the 0-degree group had less disability than those in the 30-degree group. And this could not be explained by the TICI scores that are measured at the end of the procedure, looking at recanalization and perfusion within the arterial territory. So it may be that 0-degree head positioning is also very protective against disability in that proximal period after the thrombectomy. At 90 days, we did not see a difference, although visibly, if you look at the modified Rankin, you can see there's a little tiny shift favoring the 0-degree. But again, I'd be cautious in interpreting that because we were not powered for that particular endpoint. But I think that we can kind of summarize all of this and say that these patients are more stable. They're safe. In many cases, they improve if they're at 0 degrees, and that ultimately we may be discharging them from the hospital with less disability, requiring less rehabilitation needs. We haven't really looked at anything in a randomized trial immediately after thrombectomy. We also don't know if it matters in those patients, to stay down, to get up right away and get moving. So that's something that certainly could be considered. But I think that we'd want to be very, very careful. I do not think, and I do not recommend that we try to repeat our work again, because I think that we'd really be kind of in an unethical position to suggest that patients could safely be put up at 30 degrees without any harm. So I don't think that that's the next step to be taken. But I do think that, perhaps looking post-thrombectomy, I also think that there's a great deal of implementation work that could be considered. For example, in patients that need to be transferred from hospital to hospital because they arrive at a lower level of care that doesn't perform thrombectomy and need to be moved to a higher level of care. Perhaps those patients need to be positioned at 0 degrees. I would recommend that they do be positioned at 0 degrees so that their brain is in the best possible condition by the time they arrive at a tertiary center. But our ambulance personnel, our helicopter personnel, all need to be trained on that as well. So there is, a good chance that implementation work could be done too.